Hey everybody, welcome back to the ECG of the day. My name is Reed, and before we start this video, you can go to the description and click on the link for the PDF of this document so you can follow along. And please like, comment, and subscribe to the channel to help support us and promote these videos. So let's get started. So the first thing I like to do when I look at an ECG is look at the forest, and the trees of the forest are my QRS complexes. And so I'll maybe pick this rhythm strip here, lead 2, and determine what I kind of think is going on with this rhythm. So I see I've got what appears to kind of at first glance be a narrow complex rhythm, but if you look closely, you can see maybe at this QRS that the ending of the QRS here, it's actually kind of on the borderline of maybe a wide complex QRS, and you can see that it's ticking away, not too fast, not too slow. This appears to be maybe a kind of a shorter interval beat here, and then a longer, and kind of long again. Then it starts to get a little bit shorter again and longer, and so it's kind of all over the place. And there's really not really much of a pattern to it, you would say. When I look to see what's going on, are there P waves? Are there dropped P waves? I don't see much of an organized atrial activity as I scan through all the leads here. They tell me that there's a distinct P wave before my QRSs, and so usually we think of rhythms like atrial fibrillation that causes some type of irregularity in the rhythm that is not associated with a distinct P wave, but usually we would think AFib is typically a arrhythmia that is narrow complex, irregularly irregular. And so is this possible that this could be a wide complex, so this wide rhythm, could this still be AFib? And I would say, yes, it definitely could be AFib. And the reason why is that AFib is a disease of the atria, right? And so you have these fibrillatory waves going throughout the atria that don't create any distinct P waves. And so then they bump into the AV node, and the AV node is a bystander and passes that signal down. It does that in a irregular fashion. But if somebody already has like a pre-existing bundle branch block, like a right or left bundle branch block, you're going to have a wide QRS whenever the AV node captures that signal and sends it down. And so we can kind of go ahead and eyeball that and see, we suspect this might be AFib with like some aberrancy. And if you look, we said we had a wide QRS. We said it's a wide QRS. I would say maybe 130 milliseconds. And so I want to confirm, it appears that this is an irregularly irregular rhythm. Irregularly irregular rhythm, which really means that there is no pattern to the irregularity. And I want to see if it matches any type of aberrancy patterns that we see in a bundle branch block. So I look for a right bundle branch block up in here in V1, and look what I get. I get an RSR prime in the V1 leads, and that RSR prime is really characteristic of a right bundle branch block. And so when you get RSR prime in V1, V2, the setting of a wide complex rhythm, really that's very common for right bundle branch block. And we need to continue to just evaluate the rest of our QRS, but now I'm starting to think this is probably atrial fibrillation. So we've got atrial fibrillation here, right, because there's no P waves. So obviously I can't necessarily evaluate for a P wave, but my atrial activity, you can see these kind of fine fibrillatory waves that are kind of throughout. And so we could say that this is AFib in the setting of this irregularly irregular pattern. Let's evaluate our QRS a little bit closely, or a little bit more closely, and we see we've got our axis of our QRS is upright here in lead 1. It's upright in AVF. So that tells me that the axis of my QRS is down and to the left. It's a wide complex rhythm, which we already identified is due to a right bundle branch block aberrancy. So far we've got a atrial fibrillation with a right bundle branch block. And something that you'll start catching an eye for with these right bundle branch blocks is these what we call slurred S waves in these lateral leads, V5 and V6. See, we've got these, if I look really closely here, these slurry S waves. They're not very sharp waves. They're just slurry little S waves. You also get them in the lateral leads, lead 1 in AVL. You can see them a little bit here, kind of a little slurry. Takes a little bit of time to get back to the baseline. And that's just more evidence of late forces heading negatively, so away from the lateral leads, which means that it's late forces, if I go over my diagram, going towards the right ventricle. And that obviously makes sense with our right bundle branches blocked, so it takes more time. So later on in the QRS, we have forces going that way. So we've got our right bundle branch block. Let's measure our QT intervals. And I like to just eyeball it. Sometimes I'll just take, midway point between two QRS complexes. I'll choose one here in lead 3. And just want to make sure that if I draw a line midway through that my T wave ends before then. So that's reassuring. The last thing that we can do here, I guess that we need to do before we move on, is to characterize for AFib. We said earlier that the AV node was a bystander for AFib, right? So we can't indirectly, like we said, we can't measure a PR interval because there's no PUA for a PR interval. But in order to understand how the AV node is behaving in the setting of AFib, we need to figure out what is the ventricular response, because the AFib is bombarding the AV node, and the AV node is going to send signal down once it has completely repolarized. And so that tells me the ventricular response. So what is the ventricular response here? I can't just measure an R to R interval. I can't just measure the rate from here to here because it's going to be different from here to here. So something I like to do is this strip from the beginning here to the end here. This strip is 10 seconds. So I can count the total number of QRS complexes and multiply it by 6 to get the number of beats per minute. So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So I've got 12 beats over a 10-second period. And so for my rate is going to equal 10 seconds, or excuse me, it's going to be 12 beats. It's going to be 12 beats. And we need to multiply that times 6, because there's going to be 6 times 10 is 60 seconds. And so we get 72 beats per minute. That's my rate. And so that rate here is a normal or moderate ventricular response. Ventricular response. So that's a moderate ventricular response. And then the last thing we're going to do is look for pathological Q waves and ST or T wave changes throughout that are really telling us, 1, if we've got old myocardial infarctions, and 2, if we've got any previous ST or T wave changes that might make me think there's some active ischemia going on. I don't see any here. And so let's put this all together and we get our final rhythm diagnosis. So we've got atrial fibrillation with a right bundle branch block at a rate of 72 beats per minute. So it's AFib right bundle branch block with a moderate ventricular response. So hope this helps. If you have any questions, throw it in the comments. If not, we'll see you tomorrow, and have a great day. Take care.